Welcome to the Practicing Clinicians Exchange podcast series on strategies for individualizing the management of inflammatory bowel disease. This is the first of 4 podcast episodes, adapted from a presentation conducted during a PCE Gastroenterology APP bootcamp in April of 2022. Each episode is eligible for CE and CEME credit. To receive your credit at the conclusion of the podcast, please go to pce.is/IBD or click on the link in the podcast notes. This episode is certified for 0.25 ANCC contact hours and 0.25 AAPA credits. In this episode, gastroenterologist Dr. Anita Afzali and gastroenterology NP Dr. Nana Bernasko discuss the importance of early and accurate diagnosis and classification of IBD in choosing appropriate and individualized therapies for disease management. Now, let's get started to hear about this important topic. We'll first hear from Dr. Bernasko.
As we are aware, the course of IBD can be progressive, relapsing, and episodes of remitting. The major forms of IBD include Crohn's disease, ulcerative colitis, and then about 10% of these people have indeterminate colitis, and that's when we're not quite sure if they have UC or they have Crohn's disease. At the clinical characteristics of Crohn's disease, obviously the goal for managing Crohn's disease is to get endoscopic healing. But sometimes patients can present with cobblestoning, aphthous ulcerations, segmental involvement, and then their patches presentation. And so you'll have areas of healthy mucosa interspersed with diseased mucosas. Sometimes patients will have stenosis, fistulizing disease, but for the most part, there is rectal sparing in the Crohn's disease patient, for the most part, but this is not always the case. When it comes to ulcerative colitis, we see a progression starting from the rectum, working its way around the colon. So there is diffuse inflammation. Sometimes you see erythema, loss of vascular markings. There's mucosal friability. You may see some erosions, what we call pseudopolyps, and there may be some spontaneous bleeding when that tissue is manipulated. As we're aware, the gold standard for diagnosing and differentiating UC from Crohn's disease is endoscopy. You also need to possibly do a colonoscopy as well. This enables objective assessment of disease and for cancer surveillance, and there are different scoring systems available for use. This kind of gives us a broad idea of what we're looking at when we look at these scoring symptoms without necessarily seeing the pictures, but then we're all speaking the same language with these scoring systems. Indications for early workup of IBD. This column is split into 2 for most important and very important or important. So in the most important column, if your patient presents with over about a month of diarrhea, we need to start thinking about maybe this could be IBD. Have they been having bloody stools for about a week? Recurrent perianal abscesses, this is more of Crohn's disease. Recurrent fistula, recurrent large inflamed skin tags. You may have elevated fecal calprotectin. And in children, what may be the key sign is impaired growth. In our column of importance, early abdominal pain greater than or equal to 1 month in presentation, elevated serum inflammatory markers, weight loss greater than 10% of their weight. Patients may present with hyperalbuminemia or IDA. They may have fevers of unknown origin, chronic fatigue. And always think about it when a first-degree family member has IBD history. Patients may also have arthritis, uveitis, and some other skin manifestations. And then there may be large colonic anal fissures as well. IBD severity classifications. First, let's talk about Crohn's disease. We would classify Crohn's as mild if the patient tolerates oral intake. There is no abdominal tenderness, no fever or obstruction. For moderate classification, we would be looking at that Crohn's disease patient who presents with abdominal pain, anemia, fever, nausea, vomiting. There may be some weight loss and may have no response to treatment for mild Crohn's disease. Our patients with Crohn's disease who may present with severity would include symptoms of high fever. Symptoms persist despite outpatient corticosteroid therapy. When it comes to our patients with UC, for a mild presentation, you're looking at your patient who may have less than 4 stools a day. They may have some intermittent rectal bleeding. There's no systemic toxicity. Their SED rate or ESR, which is their inflammatory markers, may be on the normal side. And there may be absence of severe abdominal pain, fever, and weight loss. For a moderate UC patient, they may be having more than 4 stools daily. Their stools may be bloody as well. They may have minimum systemic toxicity, a low-grade fever, mild anemia, may or may not have abdominal pain. Not all UC patients present with abdominal pain, so that may be present or maybe not. With your severe UC patients, these are patients who will be having more than 6 bowel movements a day. These stools are usually urgent, they're bloody, their inflammatory markers will be very elevated. And when you do an imaging study, you may see some air, edematous wall, and some thumbprinting. And they may present with severe cramping as well. Classifying disease severity is so important because this allows you to pick the right treatment for that right patient at that right time. Take away from this boot camp, utilize classification and scoring tools to diagnose and start appropriate therapy early for patients with IBD. Remember, the goal is to treat early and prevent complications from the disease. I'll turn it over to Dr. Afzali to continue.
Wonderful. Thank you, Dr. Bernasko, for the background that you've provided as far as how should we classify inflammatory bowel disease. And so now what I'm going to do is we're going to talk a little bit about how do we approach the actual management of inflammatory bowel disease. So taking a step back, I think in the past we've kind of used different terminology, top down, step up, bottom up type of approach. But we're really changing how we are actually managing our patients with inflammatory bowel disease, recognizing that we need to look at different components of each individual patient. In other words, every patient who has Crohn's disease or ulcerative colitis is different. And we've lumped it together. You either have ulcerative colitis, you either have Crohn's disease, or about that 10% that may have an indeterminate colitis. But all in all, we need to look at patient-specific factors. And those patient-specific factors includes disease activity. How is your patient at the time of your clinic visit, at that time of that colonoscopy, as Dr. Bernasko described, at the time of that initial assessment when they're filling out a questionnaire or they're obtaining laboratory studies? So in essence, disease activity is a snapshot of their current symptoms, as well as the amount of inflammation we're seeing at that present time. The movie, so to speak, is disease severity. So this is basically a reflection over the course of time, what's going to happen to our patients. In other words, what factors could potentially help us predict whether or not our patients are at a higher risk for disease progression, whether our patients are at a higher risk for need for surgery, for example, hospitalization, steroids, etc. And it's really this balance of recognizing disease activity and differentiating the disease severity, those prognostic factors that will help us predict the longer term outcomes for each individual patient of ours. When we're talking about the selection of early appropriate therapy, it's the appropriate treatment for each individual patient. What treatment approach would be for one patient is going to be very different than the approach for another patient, purely based off of both disease activity as well as those prognostic factors. So what are some of these prognostic factors? And perhaps in other disease states, such as cardiac disease, we've been able to appropriately identify some of the risk factors of which of our patients would be at a higher risk for, let's say, medical cardiac issues, such as a big heart attack, for example. But over time, we've actually identified something similar in inflammatory bowel disease for both Crohn's disease as well as ulcerative colitis, where we've identified prognostic factors that tells us really which of our patients would be at a higher risk for disease progression. Again, the disease severity, those prognostic factors. So for the Crohn's disease patients, if they are at low risk, they're likely have had this disease beyond or after the age of 30. The involvement of their disease distribution is probably limited. They do not have perianal disease or severe rectal disease, fistulizing disease. The ulcerations aren't as deep as we may see for that more severe complex Crohn's patient. They have not previously required surgery, no strictures, no fistulas. So this is that low-risk patient. What about that high-risk patient? Well, again, the prognostic factors of a Crohn's patient who has had a diagnosis younger than the age of 30, more extensive disease involvement, perianal disease, stricturing, fistulizing disease, deep ulceration, someone who's had a prior surgery. These are patients that we absolutely know that if they have some of these factors, in fact, at least 2 or greater factors, predicts that they are over at least a 5-year time period, they're at nearly an 80% risk of having disease progression and more complications related to their disease. So again, identifying the prognostic factors to help us determine whether and what is the appropriate treatment for each individual patient. The same approach happens for ulcerative colitis, where we can differentiate low risk, again, older than the age of 40, limited disease, mild inflammation, superficial inflammation. There's minimal, if any, impact on systemic absorption because of that inflammatory burden. In other words, their albumin is normal, perhaps even their CRP is normal. They haven't previously required a hospitalization. These patients are at low risk. So again, when we talk about early appropriate therapy, the appropriate treatment approach for this patient may be mesalamines or topical enemas alone. Now, the high-risk patient is a patient who, again, has had this diagnosis for a longer duration of time at a younger age, younger than the age of 40, extensive involvement, pancolitis. On colonoscopy, we're seeing significant inflammation, and we use that Mayo scoring system or the UC endoscopic index score system, both of which tells us there's active, severe inflammation, deep ulcerations. And now we're seeing that impact of the inflammation. We're having an impact on absorptive capacity, really. So the albumin is impacted where you have a low albumin, the CRP is elevated, and potentially this patient has already had a prior hospitalization for management of their disease. So switching gears a little bit aside from the actual luminal inflammation, what other components do we consider when we're talking about the appropriate treatment for each individual patient? And this is where we need to identify whether our patients may also have extraintestinal manifestations. And so inflammatory bowel disease is really a disease, what we say is from top to bottom and everything in between. So it can involve the joints, it can involve the skin, the eyes, the hepatobiliary, hematologic, kidneys, renal stones, kidney stones as an example. And what we also have understood over time with some of these extraintestinal manifestations is that some of these EIMs or extraintestinal manifestations actually parallel bowel disease activity. So what I mean by that, and I actually came up with this rule of ease for us to help simplify our thinking in regards to EIMs, which is to really say there's certain components of extraintestinal manifestations that if there's active inflammation, they're more likely, for example, to have joint arthropathy or joint pain. So what we know is that peripheral arthritis, elbows, let's use that as a peripheral, it actually parallels bowel disease activity as compared to ankylosing spondylitis or sacroiliitis. So an axial arthropathy, the spine or the back, does not necessarily parallel bowel disease activity. Dermatologic, there's skin manifestations that we see. Erythema nodosum are painful red bumps, typically over the shins of the patient. This parallels bowel disease activity. If we control the gut inflammation, usually the EN or erythema nodosum lesions actually improves as compared to pyoderma gangrenosum, which does not parallel bowel disease activity. Similarly, for ocular involvement, episcleritis or redness of the eye can actually parallel bowel disease activity as compared to uveitis or iritis, which does not. And so again, when we are identifying which patient should receive which appropriate therapy, we also need to account for whether these patients have extraintestinal manifestations. Because as you'll hear from us shortly, our treatment and management strategies will differ based off of whether and the location and the severity and the disease activity, but then also whether our patients have extraintestinal manifestations or not. So when we talk about each individual patient, really, in essence, we're practicing precision medicine in inflammatory bowel disease. How do we find the appropriate treatment for the right patient at the right dosing, with recognizing that we've optimized their medical management? We've recognized over time that our goals in our treatment strategies has also changed. Gone are the days that we said, here's some medicines. If it controls your diarrhea or your pain, et cetera, great. If it doesn't, come back and see me, and we just leave the patient alone. It used to be where we would have a visit maybe once or twice every other year with our patients. We've identified that we actually need to change our goals and our treatment strategies in order to ensure the best outcomes for our patients. So this starts with early diagnosis. As was described earlier, as far as the prevalence and the incidence of inflammatory bowel disease, we're certainly seeing a rise or an increase in inflammatory bowel disease, but we also need to recognize that our diagnostic abilities have also improved, whether this includes colonoscopy, cross-sectional imaging, the fecal calprotectin as an early marker potentially to identify which of our patients could potentially or will potentially need a colonoscopy. All of these incorporates our goal of early recognition of symptoms and early management of disease, because this is what ultimately results in the best outcomes for each individual patient. Once we've made that early diagnosis, again, disease activity, snapshot, disease severity, the full movie. What's those prognostic factors that will tell our patients that they're at a higher risk for disease progression? Based off of that, based off of disease activity and disease severity, now we're reaching into that medicine cabinet for the appropriate therapy for each individual patient. We have to individualize our approach, recognizing that based off of how significant of an inflammatory burden they have, we may be reaching for either one type of medication or another. Once we've reached into that medicine cabinet, now we're aiming for a few goals. First and foremost, we need rapid induction of remission. Basically, we want our patients to get well very quickly in symptoms. Let's be honest, none of our patients, neither you nor myself, will want to be on any medicine if it doesn't start making us feel good very fast. So, of course, we want that as well. So now we're talking about the efforts of once we've initiated therapy, we're now aiming for clinical improvement, the symptom improvement, as well as early mucosal healing. And we know that once we've controlled the mucosa, the lining, the inside of the colon or the small bowel or wherever the disease is, this is where we're going to get a better response for our patient. We call this deep remission, where we're having both clinical remission as well as mucosal healing. So that level of inflammation has also improved. All in all, aside from the active level of inflammation that we're trying to improve and that mucosal healing that we're trying to achieve, we're also aiming for preventative care, recognizing our patients are at a higher risk if they have active inflammation, for example, for colon cancer. So appropriate monitoring of colon cancer also needs to be in our workup and evaluation and monitoring strategies for our patients. We need to make sure that our patients are appropriately immunized and vaccinated. All of these efforts are going to decrease the infection risk. It's going to decrease the risk for hospitalizations, surgery, etc. And then also, let's not forget the impact of mental health. Certainly, depression and anxiety are significant in our patients who are suffering from these chronic diseases. Sexual dysfunction and sexual health is also important to pay attention to for our patients. All in all, we want appropriate therapy for each individual patient, but we want it to be cost effective. And not just cost effective as far as a dollar amount of medication or drug, but we want our patients on therapies that actually works for them. So this requires monitoring strategies as well. And this is why it matters. If you can see here from both graphs, whether we're talking about Crohn's disease or ulcerative colitis, all in all, we typically only have a very small window of an opportunity where we can find the appropriate treatment for our patients without it being complicated by having other complications of needing a surgery or developing a more progressive phenotype, fistula, strictures, or requiring a colectomy or developing colon cancer. Whether we're talking about Crohn's disease or ulcerative colitis, this is the active inflammatory component that we're trying to control. If we don't control the active inflammation, the disease will progress. For example, in Crohn's disease, the disease will progress from active inflammation to more of a fibrostenotic, stricturing, penetrating phenotype. And we'll be honest, at present, none of our medications are really that great in stricturing, penetrating fibrostenotic disease. Our medications at present for inflammatory bowel disease are really great at anti-inflammation, but not for this fibrostenosis. So again, a very small window of opportunity to initiate the appropriate treatment and make that accurate diagnosis for that patient. The same approach is for ulcerative colitis. As you can see here early on, when there's mild inflammation or superficial ulcerations or limited disease without an impact on systemic absorption with the impact on albumin, for example, we know that these patients are more likely to respond to our medications, whatever that medication is for each individual patient. The longer we wait on initiating appropriate therapy for each individual patient, you can see that they're less likely to respond to the medications and, quite frankly, at a higher risk of requiring a colectomy or having other complications. So this has been discussed over and over again as far as an international committee who really helped us establish a little bit more formal recommendations of really how we should approach our treatment targets, whether we're discussing Crohn's disease or ulcerative colitis, recognizing that, again, one of our initial short-term targets is to make sure our patients are responding to whatever treatment we've initiated for them. So this is a short-term therapy. Longer term, over time, an intermediate goal is, of course, we want symptomatic remission, meaning they're back to baseline in their symptoms. We want a normalization of the inflammatory burden with a normalization of CRP or fecal calprotectin for the pediatric children. But we certainly want to make sure that there's no impact now, any further impact on growth and development. But then our longer term targets for inflammatory bowel disease, Crohn's or colitis, is now we want a complete endoscopic healing of the mucosa, whether it's within the colon or the small bowel. Recognizing that mucosal healing, that deep remission where you have symptomatic remission as well as endoscopic healing, that deep remission, which includes the mucosal healing, that is what is going to result in the best outcomes for our patients. So you may have heard us use the word treat to target, and our targets are symptomatic. Our targets are as an intermediate evaluation of the biomarkers, and our targets are that long-term target is endoscopic healing, mucosal healing. Of course, in the future, we're aiming even for histologic, but right now we want endoscopic healing and that trying to achieve that deep remission regardless of whichever therapy you've reached into that medicine cabinet for each individual patient. So again, when we talk about what approach should we take for each individual patient, is ensuring that we are proactively monitoring their disease once we've reached into that medicine cabinet, regardless of which medication we've chosen for that patient, but we are aiming for short-term targets, intermediate, as well as the long-term targets, and ensuring that if these targets are not being achieved in that timely fashion, then it's potentially a time when we need to either consider optimizing or even changing the medication approach in order to manage each individual patient's disease.
Thank you very much to Drs. Afzali and Bernasko for that excellent discussion, and thank you so much for listening. Tune in to the other episodes in this series to learn about therapeutic options, guideline recommendations, individualized care, evidence-based health maintenance, and much more. You can access those as well as claim your CE credit for this episode by visiting pce.is/IBD.